Hello students, welcome. Myself Dr. Roshini, your OBGYN faculty at DigiNerve. So we are doing a quick revision for your INI-CET exams about abortions and your MTPs. One of the commonly asked questions, especially your MTPs. So let us begin for the quick revision. So by definition, what is an abortion and what is a stillbirth? Stillbirth is no sign of life after 28 weeks or 500 grams. That is your after period of viability. It is stillbirth. Before period of viability is your abortions. Okay, so period of viability is one of the questionable, debatable topic as of now. Some people say 22 weeks, some people say 26 weeks. So on an average, let us keep it for 24 weeks. So coming to the different types of abortions, it is threatened abortion, that is where the progress of abortion has begun, but it is not progress so much that you cannot stop it from here. You can stop it and help her to continue the pregnancy. So here is the only abortion when you give appropriate treatment and she can continue pregnancy. You can give adequate rest or treat the subchorionic hemorrhage, give progesterones, give sustain hormones, then you can help her to maintain the pregnancy. So that becomes your threatened abortion where you can revert back to her continuation of pregnancy. Other than this, all are where you cannot continue pregnancy. Inevitable is it is progress so much that you cannot come back now. अभी कोई पीछे देखना है नहीं. It is going to be an abortion for sure. Then coming to incomplete abortion, the part of it is come, the part of it is still remaining. Then complete abortion, everything is come out. Missed abortion, she has no signs, but when you read a scan, there is no cardiac activity at all. So again, it is a case of missed abortion. Septic abortion is complication of any of these where she is associated with infections. Okay, induced abortions are your MTPs where you yourself or the person herself is not wanting to continue pregnancy and wants to terminate it. Coming to threatened, where there is more bleeding, you can give treatment and help her to come back to normal by giving prolutone, sustain, progesterones, all these things, and help her bed rest and help her to come back to continuation of pregnancy. But if it doesn't act, if she continues to bleed a lot, then she'll end up going to inevitable abortion where there is no look back. Then part of it comes out, then it becomes an incomplete. If everything is coming out, then it becomes a complete. After this everything came out, then it becomes complete. If it is not expelled completely, then if it gets infected, then it becomes a septic abortion. So this is how the sequel of abortions happen. Coming to the causes of abortions, commonly is your aneuploidies, euploidy, anatomical causes, environmental causes, infections, parental causes, immunological cause, iatrogenic, maternal diseases, habits, and endocrinal causes. So what are they? The commonly in your first trimester, genetic cause is the commonest cause. In second trimester, anatomical cause is the commonest cause. So you aneuploidies, chromosomal anomalies come here. Whereas endocrine like thyroid or luteal phase defect, Apla syndrome, SLE syndrome, and infections. Here mostly your uterine anomalies like cervical incompetence, septate uterus, bicornuate uterus, all these things come. Maternal disease, infections, SLEs, and idiopathic. So here what are the environmental causes? The stress and the environment or lifestyle. Infections like your torch infections, and immunological cause like your SLEs, and iatrogenic causes like maybe IUCDs or hormones or other medications that she's taking, and endocrinal causes or metabolic causes maybe your GDM, hypothyroid, no more than GDM, over diabetes mellitus, hypothyroid, renal failure, all these things. Okay. Coming to the sepsis, one of the important things that you should know about this is it is mostly following illegal abortions done by a untrained persons and in a it is a type of iatrogenic induced kind of infections, mostly following incomplete abortions, that to following injuries, especially bladder or bowel injury associated is there, non-sterile technique has been done, or following amniocentesis and chorionic villus sampling. These are invasive methods of prenatal diagnosis, isn't it? Amniocentesis, CVS and all are invasive methods of prenatal diagnosis. So when you do in unsterile manner any investigation, especially invasive procedures, then they have more chance of septic abortions. The grading that you should know, it is grade 1 if it is confined only to uterus, grade 2 if it is involving the adnexa, the tubes, ovaries and pelvic peritoneum. But if it is generalized, it is grade 3. It is mostly following a criminal abortion or illegal procedure. They have renal failure, oliguria, DIC, septic shock, and they finally end up in their life. Okay, this is very painful to see, especially if young girls come like this. Okay, coming to the sequelae of septic abortions, most common is your infertility. Okay, they will have infertility for n number of invariable reasons. Other than this, they can have chronic PIDs, chronic pain abdomens, or a severe infection leading to hysterectomies also. Okay, so they have failed, or secondary amenorrheas are there. So these are the late sequelae of second septic abortions. Coming to cervical incompetence, so this is one of the commonest cause for recurrent pregnancy loss. Okay, recurrent pregnancy loss, RPL, that is 2 or more pregnancy losses are there, then you say it as recurrent pregnancy loss. One of the commonest reason second trimester is your incompetence. Other than this, you can have APLA syndrome positive or SLE patients, or your overt diabetes mellitus. They have more chance of having recurrent pregnancy loss. So commonly asked is your cervical incompetence. So what history they give you, like a gravida 4 patient, per abortion 3 she had, all were second trimester abortions, and that too they'll give you a clear history. She had a painless abortion. Okay, painless abortion. They usually do not have any pain, only in the end moment they will go to the washroom and do some bearing down, maybe just like how they pass stool. For that much pressure also the fetus would get expelled. Okay, or they may have mild to mild fullness in the pelvic. That is the only complaint they may have. Pain abdomen would not be there at all till the end stage. Okay, this is the history. Okay, if the history is indicated, then you'll, what is your next step? If they ask, do a scan to see viability and cervical length. If it is less than 2.5 centimeters, then you'll have to do a cervical stitch. Okay, so this cervical stitch, what are the procedures? It is Shirodkar's procedures, or you can do a McDonald's procedure. At the internal os, like this, you will tie up as high as possible. At the level of the internal os, you will tie and give the support. Under anesthesia and post-operative, you have to give hormones and follow up the patient. Okay. Next, coming to MTPs. So MTP is a deliberate termination of pregnancy either by medical or surgical method before the period of viability. Initially, it was introduced in 1971, the MTP Act, this you should know, and it was enforced in 1972. The recent 2021 amendment, I'm going to tell you further. Coming to the indications, there are only 5 indications for MTP. First one being your, let us take it as rape victim or social victim. Second one being a contraceptive failure. These are the common causes. Then is your viability of the fetus. Okay, there is no viability of the fetus even if we continue pregnancy. Fourth one is continuation of pregnancy is going to seriously deteriorate the maternal condition. Okay, deteriorate the maternal condition. And lastly, anomalous fetus is there. Okay, anomalous fetus is there which we cannot continue the pregnancy. Coming to the methods of termination, you can use medical methods, surgical methods. The medical common methods are mifepristone, that is your 200 milligram is the dose. Misoprostol, it is microgram. Okay, MCG. Misoprostol is MCG. Usually 400 to 800 microgram is given. Methotrexate 1 mg per kg body weight is given. Dinoproston, this is prostaglandin E2 gel. This based on the site you put is the dose. Remember, dinoproston is given only for second trimester abortion, that too late second trimester abortions, not otherwise. And first trimester is not helpful at all. Mostly we use dinoproston in induction of labor. In term patients, when we have to induce labor, that is when we use dinoproston. Coming to surgical method, mechanical manual vacuum aspiration or suction evacuation, dilatation and curettage, or for 12 to 13 to 14 weeks, intrauterine installation of hyperosmotic solution, and hysterotomy. Hysterotomy is just like your cesarean section. You do an incision on the lower segment and you remove the fetus out. This is called hysterotomy before the period of viability, and after the period of viability, it is cesarean section or or LSCS, lower segment cesarean section. Complications of MTP. Immediate complication is injury to cervix, uterine perforation, hemorrhage, shock, thrombosis and embolism, post-abortal triad related to medical dose or drugs that you use. Remote complication being menstrual disturbances, PIDs, corneal block infertilities, car endometriosis, synecdoche and secondary amenorrhea. This is the common complication, be it following abortion or following an MTP. Obstetrical particular complication would be your cervical incompetence, especially if the curettage is done in the cervical region at the internal os. Okay, that is when they have incompetence. Ectopic pregnancy because of intrauterine adhesions and ruptured uterus if the uterine thinning has happened. Okay, coming to the recent amendments, the 2021 amendment, the initially MTP was only for a married women. Now it is even for unmarried women. Then gestational age was only till 20 weeks. Now it is up to 24 weeks for rape survivors, and even beyond 24 weeks if it is an anomalous fetus. But only thing it should be with a medical board approval. But remember, if it is a contraceptive failure, it is only till 20 weeks even now. Okay. Medical practitioner who can do is 1 RMP for 12 weeks and 2 RMP. That is your registered medical practitioner until 20 weeks. Now it is only 1 till 20 weeks and 2 for 20 to 24 weeks. And it is a complete medical board after 24 weeks. Coming to the breach in confidentiality, this information of MTP should not be leaked to anyone from the hospital. Okay, this source or document should be very much confidential. If it was fine of only 1,000, but now along with fine, it is an imprisonment of up to 1 year. Coming to quick revision of MCQs before we end, the cervix is closed in following types of abortions. Threatened abortion, yes, it is closed as the cervical os is closed. That is why we can continue pregnancy by appropriate treatments. Yes, it is closed. Inevitable abortion, no, here the os would have been enough open that the products are already coming out. That is why you cannot stop it anymore. So here the os will not be closed. Missed abortion, again, os is closed. That is why they have no symptoms. Complete abortion, yes, after the abortion, our house will definitely get closed, isn't it? So answer will be B. Next question. A gravida 5 female with history of 4 previous second trimester abortions. So I told you this is the type of history they give. Presence at 24 weeks with funneling of the cervix, and length of cervix is only 20 mm. Most appropriate management would be bed rest. No, that would not help you anymore. Fothergill's operation is done for cervical elongation, not for incompetence. McDonald's or Shirodker stitch is the correct answer. Administer mifepristone. If you do that, she will end up abortion, isn't it? Then, which of the following is not true about 2022 amendment of MTP Act? In case of fetal anomaly, the upper limit has still been kept to the same as earlier 20 weeks, is it? No, it is up to 24 weeks for 2 medical practitioner, and more than 24 weeks with a medical board, you can still terminate for a anomalous fetus. So this is the wrong answer. Termination is permitted up to 20 weeks of pregnancy if it occurs due to failure of contraception. This is correct. Upper limit of termination has been extended to 24 weeks. This is also correct. Registered medical practitioner is qualified to perform MTP who has assisted at least 25 MTPs in an authorized center. This is also correct. So next question, all of the following are medical methods for use in the first trimester pregnancy termination. First trimester abortions, MTP, what do you use? Mifepristone, misoprostol, methotrexate. No, dinoprostone is used in term patients or in second trimester abortions, or for induction of labor in term patients. So this is the wrong answer. So this ends about your MTPs and abortions. I hope this helps in your INI-CET exams. All the best. Thank you.